Tim's going first. You probably bring his up.
Yeah, yeah.
Unless you had something.
There you go,
as
there you go,
moderator.
there you go. Perfect.
I love it.
Thank you.
It's not usually that way.
Similar things. My point is that there's substance use side, the preponderance of evidence, especially since it's being meta-analysis, come up with negative effect.
People are finding that incredibly controversial.
You mean
Like that's protective. That
Still? Still?
but people, you mean the researchers that you work with?
no researchers who do randomized controlled trials with the
No,
MTA.
no, but the MTA, I have to tell you, the MTA, there's so many problems with it. Only 6% of their people are on meds. And so, don't worry about it. But my point is, we have the randomized control trials. That actually show reductions. The naturalistic studies show you negative, but the huge studies, all these big large registry studies are showing improvements. You know what, I had a comment, I destroyed it. I was at ACAP, they presented the data, and I got up and I got to see it. I destroyed it in front of them about all of the issues that they have. And it's a small data set, and it's irrelevant compared to the thousands. That's thousands of people who have these registry studies.
Right, and some point that I'm making is that we're actually finding that the highest characteristics before you can get first ADHD medication, at least for adolescents. And so I think the most stressful
Another issue about the randomized controlled trial, the MTA is not randomized for substance use. It was randomized for med administration when the kids were 9, and it was only valid for that randomization. It's not randomized against observation. And then they're using propensity scoring, and only 6% of their patients are still alive. It's irrelevant. When you look at this small sample, they don't have power to do it. So I don't worry. Well, yeah, but none of that stuff is not being published. Everybody was like not into it at ACAP. Nobody was into it. Nobody was into it. It does. That's why you'll see. So my thing is, at the end of the day, you're going to hear more about it. Our registry studies, and those that I've been involved in, other ways, huge.
Right, huge monitoring the future stuff.
Yeah. So you don't have to be equivocal here. Don't worry about the MTA here.
So it'll be fascinating afterwards. It's just that I talk explicitly about quantification, and we always think about errors of commission.
Oh yeah, which is what the huge issue. Omission is everything.
So I think
We're all on the same page. I'm going to get started so we have enough time. Okay, I'm going to get started. If everybody could take their seats, I'd appreciate it. We have a great panel here, and I don't want you to miss out on a minute of their wisdom. So if people could sit, that'd be great. Okay. Great. My name is Frances Levin, and I'm the director of the Division on Substance Use Disorders at Psychiatric Institute. And you may wonder why I'm up here. I'm an addiction psychiatrist, but I've spent the last 20 years evaluating and treating ADHD and substance use populations, and will tell you that it's pretty sad, but most of the treatment programs in the United States do not even think to recognize or assess for ADHD or treat ADHD, despite the effect and negative effect it has on treatment outcome for people with substance use disorders. Certainly, I'm seeing it at the end stage, people who are coming in for treatment as adults in which their ADHD unfortunately was not recognized. The vast majority of people that I see in methadone programs or other treatment programs were never diagnosed with ADHD, and it's often an epiphany and a sense of sadness that it wasn't picked up when we find we have it together. And I think it's relevant to what we're going to be talking about today, and that is new data on treatment of ADHD and impairments in adulthood, and how many of the impairments that I see by being a substance abuse expert or other people seeing people with depression or suicidality, often these patients also have ADHD that's either been unrecognized or inadequately treated. So with that, I'm very excited to have this group of panelists that we have today because I think they've got some very exciting data to talk about in the importance of early recognition and treatment. As I said, this is on new data on treatment of ADHD and impairments in adulthood. And while each of our panelists will be talking about longitudinal as well as registry data and their own clinical experience, I think the implications of this data, which I think is very clear, is that the importance of both prevention of perhaps these future negative outcomes that could be done by the recognition and treatment of ADHD and mitigating these harmful outcomes into adulthood will be discussed by our panelists. The way we're going to structure this is each speaker will talk for about 20, 25 minutes, I hope, and then answer maybe 2 or 3 questions so that we can leave enough time at the end, hopefully almost a half hour, to be able to address questions and have a discussion with you in the audience. Our first speaker is Dr. Tim Wilens. I've known Tim for a very long time. He's been dare I say, role model. He's the chief of child and adolescent psychiatry and co-director of the Center for Addiction Medicine at Mass General. He specializes in the diagnosis and treatment of substance use disorders, and he's extremely well published. He's written over 350 articles, review chapters, books, and editorials. He's a consultant to the National Football League and Major and Minor League Baseball. He's also worked with Bay Cove Human Services and Phoenix House, and he's consistently named as one of the best doctors in Boston and in America for psychiatry. His talk is going to be on what effect does ADHD medication treatment have on the later risk for substance use disorders. So on that note, Tim?
Thank you.
Thank you very much, and in the spirit of Joe Biederman, I don't know if Joe's here, but I have 500 slides in 20 minutes, so welcome. I want to welcome you, and I also want to shout out something about Fran Levin is really one of the single reasons that many now addiction units ask and screen about ADHD. A lot of your work has really helped to change that, and also how do you treat that. So here are my disclosures. Funding from my lab for almost 30 years now has come from the National Institute on Drug Abuse, who's really interested in this area. We're going to be talking about the risk for SUD and ADHD youth growing up, just as a backdrop, and then talk a little bit about some of the literature on the impact of ADHD on later substance use. There's overlap with Brian D'Onofrio's talk, so I'll take out a few slides as we go. We realized this as we were standing up here. We were talking about our favorite studies until I realized some of those were his studies, so I really shouldn't present his data. So I'm going to start with Hunter Thompson. I hate to advocate drugs, alcohol, violence, or insanity to anyone, but it's always worked for me. I'm going to remind you, this is the world of ADHD. Here's the world of APSARD, but this is the world of substance use disorders, and they overlap. And that's the Venn diagram. That's in the untreated state, what you can expect to see if you don't treat ADHD, and how many, roughly, with substance use disorders, adults have ADHD. This is just looking, if you start with adults with substance use disorders, SUD is substance use disorders, drug or alcohol abuse or dependence. You can see that the range is, it's all over the place, more with alcohol, a little bit less with other substances, but a meta-analysis that was done in Europe basically shows that if you look at all of the studies to date at that point, about a quarter of adults with substance abuse or substance use disorders have ADHD. So it's a lot. If you reverse that, I think you can see the pointer up here, and you start with individuals who have ADHD, as they grow up, how many develop, in this case, substance use disorders or cigarette smoking, to the right of this would indicate an increased risk for developing, in this case, substance use. To the left would be a reduced rate. You can see that overall there's an increased risk for substance use disorders, and roughly 2 to 3-fold, most of the studies showing that, about a 2 to 3-fold risk in the untreated state. And if you start here for cigarette smoking, it's about 3-fold increased risk for developing cigarette smoking in ADHD. We also know some other issues. A lot of this work also Fran and her laboratory has done, and I'm just going to scroll through it. So it's not a good phenotype. We don't want people to develop ADHD and substance use disorders. It's one of the most feared outcomes over time with ADHD, and the question that I'm going to be addressing and you're going to hear then followed up on is, does treatment, what does it do? Does it mitigate that risk? And this is what we're really talking about. So you start here. This is the risk of substance use in youth with ADHD and controls. It's relatively low. It's not really differentiating in adolescence if you take out other disorders. But by adulthood, almost 50% of adults with untreated ADHD develop a substance use. So can you mitigate this risk to at least put it closer to the population risk? And I'm just going to skip over this. One of the issues I want to comment on that's a big issue that you have to think about, there's two issues when we look at these samples. Baseline severity has a lot to do with who gets medicated, and who gets medicated, well, then you can look at outcome based on medication status. Let me say, the more severe illness leads to poor outcome. We know that. If you get people with stage 4 carcinoma versus stage 1, you have a worse outcome. Almost every disease state runs that gamut. We also know that more severe illness leads to more treatment. And it's easy to say more treatment leads to poorer outcome. So if you look at those people who die or succumb from cancer, you could erroneously say that when we looked at people who died from cancer, they were on high doses of chemotherapy and multiple chemotherapeutic class and agents. Ergo, chemotherapy causes cancer. And that's the erroneous thing that you have to watch for in a lot of these naturalistic, longer-term studies. Are they matched at baseline, or can you control at baseline? Another issue is effective monitoring in the other direction. Kids who are on medication are being monitored often more closely. And what is the effective monitoring on long-term outcomes? You're being watched, you're supervised, they're going in for visits. There's clearly an effective monitoring. I'm not sure we have the answers to this, but I want you to think about that as we talk about things. So let's move on to prevention. This is one of the first studies. This was studied back, one of the first studies that looked at this issue. It was in a 5-year follow-up study and basically showed that the highest rate of substance use disorders in this sample growing up was in the unmedicated. The medicated group were slightly higher than controls, but were statistically less than the unmedicated group. And there was one of the first signals in a relatively small sample, but still sample, that there was differences. Now this is following kids into adolescence. We subsequently did a meta-analysis, and you can see the samples there. There are a lot more samples now, and in this meta-analysis we had about 1,200 kids involved. And what we found was that the majority of studies showed reduced risk, and that reduced risk was about a 2-fold reduction in the risk, bringing it back closer to population norms. That's the good news. The other finding we had was more of an adolescence, but we saw that that protective effect was being lost in adulthood. That's the bad news. Here's a study, and I just want to go back and say one other comment about that. For a while, that was all that was out there, and that was guiding that we were seeing some effect. In the interval, there were some studies done. So this is a study done in our group that was looking at, these are secondary outcomes looking at kids over time in the initiation of cigarette smoking. This is an adolescent group, and this is looking at the development of cigarette smoking in those kids who were not stimulant treated and those kids who were stimulant treatment. And the difference here is this sample was not randomized for severity, but they were similar at baseline when we looked at stimulant treatment. So there, the baselines were the same, and in this prospective trial, which was looking at actually bupropion, when we go back and look at were they on stimulants, yes, no, it was actually the stimulant effect that was most related to a reduction in the likelihood to start cigarette smoking as these kids went through adolescence. Another study that was done by our group was looking at, this is a prospective study of oral methylphenidate. It was an open study up to 2 years. You're not allowed to do randomized trials that long through adolescence, but in this study, we also had other types of samples that we were following at the same time. And if you look at the sample that was on oral methylphenidate compared to those who were on other medications for ADHD in the clinic, compared to a contemporaneously collected group of kids not receiving medications, the ones who were at the highest risk for using cigarettes were those not treated for their ADHD. Those receiving meds in our clinic in this trial, or those who did not have ADHD, were at the lowest risk, and this was a prospective trial. Coming back, this is another naturalistic study, and this is what seemed to be the case in adolescence. It was the untreated samples of ADHD were at the highest risk in this case of developing substance use compared to the treated risk group. Again, signal being in adolescence, we saw it, but when we looked at this into adulthood, there was no difference. And interestingly, this is similar to the work from Benusa, Klein, and all that. In adults, you start to lose that effect. Now, the MTA also shows similar findings, and they just recently presented their data. The problem with a lot of these long-term studies into adulthood, and Brian, I think, will talk a little bit about this when he talks about the medications, many of the people were not on their medications anymore, and you can't force them to be on medicines, and it gets very hard to start to go back and look at that, or at least it was at that time. Come along a influential meta-analysis. This was done by Humphreys all in JAMA Psychiatry, and I don't expect you to read this. By the way, all the slides are online. You can have them if you reach out to me and you want copies of the slides. I'm happy to give them to you, the actual slides. But in this meta-analysis, again, to orient you, anything to the right would mean increased risk. Anything to the left would be a decreased risk, and this is the combined risk here. What they found was when you looked at the data up until really 2010, that you found no real effect for alcohol. Similarly, no real effect for cocaine. And maybe the opposite effect for nicotine, although it was not statistically significant. So basically, their conclusions from Humphrey was we didn't see plus, we didn't see minus. This was based on about 2,000 individuals that were followed, largely in naturalistic samples, again, with the caveat, we don't know who was on medications or not. People doing the best job they can. And you're going to hear from Russ Barkley, who talks about his sample. People do the best, but you can't assure that they're on meds through all the time. After that, I think what's important is to take a look at what are some of the data that's sort of emerged. And what I'm positing is that the naturalistic studies are sort of at are not showing plus or minus. Where you really start to see the very positive effects are in the bigger studies, in the more recent studies, in the big registry studies. Those studies are pretty uniformly showing strong protective effects where they have the power to look into that. So here's one study that was done, a big study that was a European consortium. Many of the people are here today. And in this study, they basically found that stimulant treatment lowered the risk of developing substance use disorders, but in this case, they didn't find nicotine dependence to be any different. And this is following kids now through the age of risk into young adulthood. You're going to hear more about some of these studies, but this is looking at a big Swedish registry study. Paul Lichtenstein, Brian's involved, Henrik Larsson, a number of other individuals. This was a real important study in the New England Journal of Medicine. And this looked at treatment of ADHD and criminality, and I think you may be seeing this again. What I want to point out are the sample sizes now. So in our meta-analysis, we had over 1,000. In Humphreys, it was over 2,000. But now we're into the sample sizes of 25,656 with ADHD, roughly half on medication. Now we are actually having power over time to start seeing things. Here's looking at criminality, and they showed reductions in criminality associated with treatment. I just realized that somehow that got knocked out. But the solid lines are the treated, and these are the untreated. So you can see treatment reduced it, particularly in men, criminality, which is important for substance use because 50% of those crimes were drug-related crimes. And drug-related crimes are directly correlated to drug use disorders. So it was one of the first signals we had from the Swedish registry study that, wow, there must be a huge reduction in substance use disorders. And again, you're going to hear more about this, but I want to show you just one of the take-home messages from Chang. And the reason I'm skipping over these again is Brian's going to talk about this more, is in the reanalysis of that same data set, in this case you have 26,000 men and 12,000 women, about 50% on stimulant medication, with ADHD, 50% on stimulant medicines. Again, huge sample sizes, massive sample sizes, and the capacity to really mine data and look at multiple data sets simultaneously. Who's getting medicines, who's not, when are they on them, when are they not on them, and Brian can talk more about their methodology. The striking finding we see here is two things that they help pick up. Periods of medicine versus non-medicine, a 25% reduction if you were treated versus when you weren't treated. And the other thing I want to just point out is if those who started before 15, there's an age at which you should start the medication, had a 60% reduction in the rates of substance use disorder. This is a study that Mass General collaborated with the University of Michigan, my alma mater, the team that did not make it into the championships. Not that I have an issue about that. I can hear Rick out there making comments about Ohio State. But this was a study that was done. This is U.S. data from 2013. It was a cross-sectional study of high school students. Notice the sample size, 40,000. 12% of them on stimulant medications, and then they had controls not on medication. They looked at ADHD and a whole host of other things, including age of onset of stimulant, and looked at outcomes, looking at cigarette, marijuana, alcohol, and other substance use. This is a busy slide. I'm going to show you 3 back-to-back, so I just want to orient you to this. There's a couple of things we're looking at. Does treatment reduce the risk? Is there an age effect, like they showed, they gave us a sample of from the Swedish study? And what's the age that seems to be the better cutoff? So here we had stimulant initiated before the age of 9. This is this group. The stimulants were started at age 10 to 14 and started late in adolescence. Here's the percentage that smoked. Here's your population controls over here. And then about 1,200 were on non-stimulants for ADHD. So in this case, what you're seeing, this is sort of the sort of spectroscopic pattern you're going to see through all of this is you see trends to those who start their medicines earlier and are on longer duration. This is the duration. So you would have started it before the age of 9 and you were on it for at least 6 years through your life. You can see that those who start earlier and both from an age perspective and for longer durations were closer to the population controls than those, in this case, who started early but were only on it shortly, or those who started it later, between 10 to 14, and were only on it for 3 to 5 years or less than 2 years. Or in this group, you started it in adolescence, and were only on it for relatively short duration. So here we get a signal. Earlier starting it by age, and longer duration was reducing the risk close to population controls. And in fact, this was statistically not different than that. The same general pattern is what you see for substance use. Any substance use. Here you can see it looking pretty linear, and let's say in this age group, short duration, medium duration, longer duration, and age 10 to 14. Only those who were on longer duration were closer to the population controls. Short duration and starting it later was not protective. People getting at it, it's a busy slide, but it's a lot of information, but we keep seeing that. And for past year marijuana use, again, in this large cohort of individuals, we see similar things. Again, starting it earlier than 9, longer duration, led to indistinguishable from population controls. Contrast that with adolescents who are starting it after the age of 15 and only on it for 2 years. If you look at those who are longer duration, everybody with the longest duration, just when do you start it? So Brian, one of the things Brian said to me is, we're not sure when you start. This gives you at least a snapshot into what we're seeing and what I think is a protective effect later on. And that is, here's the population risk. Here's if you start it before age 9 and chronic duration. That's statistically not different. And what happens if you start stimulants later and even later? I think that's a pretty compelling, almost dose-response kind of look in terms of that. I'm going to go over this just for time because you're going to see this presented. I apologize, but you're going to see this presented. Honestly, I don't mean to be humble, but it would have been presented a lot better by me than Brian. But, you know, it is his work, so I do feel compelled to go over it. I want to end with something that's a little bit different. I have a couple minutes. So this is kind of very recent work that we did, again, with the University of Michigan. And Sean McCabe actually is a really great researcher, and he's a really good guy to work with. And so we've been interested in prescription stimulant abuse. And one of the things that I put out there into the universe for program next year is to talk about prescription stimulant misuse and abuse. There's a lot of information about it. But this is something that we thought was using the Monitoring the Future study, and this was looking at 8,300 individuals. And what they did is they looked at age 18, and then we followed them up and looked back at age 35. So it's basically a 17 to 18-year follow-up at age 35. One of the questions we had is, so what if they misuse stimulants? Does that predict anything later on? I mean, so what? We know short-term, and there's a lot of stuff we can talk about. So this study is really looking at if you misused stimulants when you were up to age 18, does that have any connection to what happens when you're 35 years old? You're clearly through all the age of risk for substance use. And here's just to let you know, in this study, 1 in every 6 students were on prescription stimulants, and let me show you the data here. So let me orient you. This is looking at people who are on ADHD were medical use only. This is medical and non-medical. That means you may have had ADHD. It was prescribed to you, and you're screwing around with your stimulants. I know none of my patients ever do that, but I hear about it out there. And this is individuals who just were non-medically using stimulant medications. This is the likelihood to make a diagnosis for substance use disorders at age 35. This is at age 18. This is at age 35. Medical use only, there was no increased risk over population. This is yet another study that shows, by the way, kind of in a backwards way, further shows that in this sample there was no increased risk for substance use in people who were treated for their ADHD and took their medications appropriately when they were in high school. This is those kids who were screwing around with their medicines but were prescribed it. So they were at almost 1.5 times increased risk for a substance use disorder 18 years later. And the kids here who are just screwing around with their with stimulants, anybody out there who is using stimulants, they may or may not have had ADHD. And I have data that would show, actually, a lot of them don't have ADHD. I used to think everybody did who screwed around, but that's not true. They're at increased risk 15 years later. So stimulant misuse, particularly up to age 18, actually predicts bad outcomes. The other issue is for stimulant misuse, and actually this is important for another reason, and I'll tell you that in a second. This looks at how many obtain associate's degree or higher. This is the no medical or non-medical use of control group. This is those who are treated medically for ADHD. Just parenthetically, when people say there's no long-term outcomes that show that medication improves long-term outcome in this case, in this group, this was statistically not different than that group. Medicated ADHD looked very similar to the control group in here, in 7,800 people. That is, and we looked at that. We had power to say that those were equivalent. It's lower, but it's that. The group that actually did the worst were those who were screwing around with stimulant medications at age 18. They were significantly lower in terms of academic achievement. And there were a whole lot of other functional outcomes. I'm just showing that one, but that were all in the same direction. So it's probably actually really important if somebody's screwing around with stimulant medications and when we look 15 years later. So in conclusions, prospective trials of treated children and adolescents show improved cigarette smoking. What I didn't show is some SUD outcomes for time, but they were very similar to that. Naturalistic studies show improvement in adolescence, but it's equivocal in adulthood. More recently, and you're going to hear more from Brian about this, the large registry studies, sample sizes that are dwarfing the smaller studies, are showing substantial reductions in cigarette and substance use. And that last study I showed that stimulant misuse with or without ADHD is actually associated with significant functional impairments and later SUD in mid-adulthood.
Great.
So, thank you.
Two questions? Okay.
Are you kidding? It's you two who are going to ask the questions? Is there anybody else who has softball questions?
It is a free
Jesus.
world.
So my name's Alan Zemetkin. Tim, I want to ask you an extremely provocative question.
Oh, that surprises me, Alan. That really.
And those who know me know that this is my style. I would like to preface it with I am a 100% believer in the data you presented, and I tell every single one of my patients that what you just presented is true, and I believe it. But because I'm an intellectual, I want to ask you an outside-the-box question. Is that enough drama? Have I built it up enough? Okay.
And you're taking all the time, so Jeff can't ask. So that's good. Keep going.
Okay, all right. So here's, again, it's an intellectual question. It's not a real world. Is it possible that it's treatment and going in to see the doctor to get your refills and having parents who get you to, and it's, I mean, I don't believe this, but is it possible it's the treatment and not the medicine?
Oh, listen to that. Well, so first of all, I absolutely reluctantly have to agree with you. No, monitoring, when I put that special slide on monitoring, I actually think there's a lot to be said about monitoring. It goes with a massive literature in addictions in kids that supervision, monitoring of children reduces substance use. So the answer is there could certainly be an effect. The only argument I have against that, and I didn't want to go too much into it because of time, and I wanted to focus more on stimulants. If you look at the monitoring the future data, and you looked at the non-stimulant, we didn't show as much a protective effect with non-stimulants, even if we ferreted it out by age group and stuff. So there's something different about non-stimulants and stimulants, and I think it has to do with effect size and effectiveness. But I do think monitoring is critical, Alan. It really is. Oh, now Joe stepped up. Thank you.
You can cut him off if you want.
Yeah. Oh, yeah, I'm going to cut Joe Biederman off. Yeah, okay.
This is actually not a provocative question. It's actually a small question. I think it was the McCabe study.
Yeah.
You said people who were misusing
Yes.
had greater risk. I just wanted to know what the definition of misuse was. Are we only talking about people who were taking more or doing things like that, or are we also talking about misusing like non-adherence? Are we talking about people who didn't necessarily take more but gave drugs to other people? But
Yes.
the fact that they were fluid represented risk, was all of that included?
So that's a
Parts
great
of that?
question. So they have very tight definition, what they call non-medical use, NMU. And non-medical use, briefly, is some of what you said, which is you're using your own medicine at higher than or at times other than what you should, or you're using medication that is not prescribed to you. It does not include diversion to other individuals. There's other papers on that. So it would be your consumption outside of the box of what was prescribed to you, or more commonly, you're taking something that just wasn't given. Higher use than you, that's exactly right. Using it, we published a paper in 2006 that shows that 11% of our individuals misuse the medicines we prescribe. We know that at least 1 in 10 are doing that.
Tim, two related questions. One is the reasons for the misuse. Do you know this data about that?
Yeah, the biggest reasons for misuse comes from Christian Teeter at Maine, and he works with the McCabe group, and we replicate it in our study. Helping them study for concentration for that. Only 30% say that they're using them to get high, et cetera. But having said that, there's data that shows that if you look at immediate release misuse, 40% of that is intranasal. They're snorting it. I find that, and then when I talk to kids about that, they tell me it's to get high, but a lot of them do it because they've learned that they get a faster onset of action if they snort. It doesn't take 45 minutes. It works within 5 minutes.
Is there any difference in outcomes between those that use it to get high from those that used it to do all-nighters or to study?
That's a great question. We're looking at that currently. I don't know if people have actually ferreted that out, Joe.
The final is a comment, not a question. Considering that adherence is dismal, what actually means being treated, no?
Well, you know, I took out a slide, and now I wish I hadn't, because one of my slides after monitoring was exactly what you just said, adherence, which is one of the big issues with the naturalistic studies. I think I'm getting, we have to.
Yeah, I apologize. We'll definitely come to you first at the end. How about that? Okay, great, thank you. Okay, our next speaker is Russell Barkley. Russell Barkley is a clinical professor of psychiatry at Virginia Treatment Center in Child and Virginia's Commonwealth of University Medical Center in Richmond, Virginia. He's a diplomat in 3 specialties: clinical psychology, clinical child and adolescent psychology, and clinical neuropsychology. People probably know he's a clinical scientist, educator, and practitioner. He's published 23 books, rating scales, and clinical manuals numbering 41 editions. And he's published more than 270 scientific articles and book chapters related to the nature of assessment and treatment of ADHD and related disorders. He's received numerous awards from many organizations for his career accomplishments, contributions to research in ADHD, to clinical practice, and his dissemination in science. And I'm incredibly honored to have you here today, Russell. We don't have, and he's going to be discussing about health outcomes of ADHD and do they adversely impact life expectancy. So thank you.
Thanks.
Thank you.
How do we get this?
Oh, yeah, there you go.
Thank you.
You got it?
No. Oh, I
You can
guess
do
it's-
this, yeah. Wait a minute.
Sorry, we're having just a little.
Yeah, I can't figure out how to pull it down. Hold on a second. Wait a minute, there's the cursor. Hold on a
Okay,
second.
there
you
we go. Okay. No.
Double click?
No. Good.
Okay, there you go.
Okay. Well, good morning, everybody, and thank you for coming out this morning. I want to thank the APSARD board for allowing me to speak to you this morning. Given that our time is short, and unlike Tim, instead of throwing out slides, I'll just speak more quickly. Not that I don't do that anyway. But this is my disclosure slide, and I always like to take a moment to editorialize just for a second about this. When we disclose, I find it absolutely silly and hypocritical that the only thing people disclose is affiliations with pharmaceutical companies. I think that that is ridiculous. Steve Frone and I have talked about this many times. Your life is rife with conflict of interest. You should be disclosing all sources of your support, not just that from the pharmaceutical industry. Many of us make as much or more money off of books, rating scales, parent training manuals, online CE courses, and so on, as we ever make from the pharmaceutical industry. So in that spirit, and I noticed Tim did the same thing, thank you, Tim, this is all of my sources of support for the previous 12 months. And of course, I'm going to skip over it because you can see at the bottom that that's the pharmaceutical as well as other industries as well. So I want to speak with you about something that has intrigued me since the mid to late 1990s when we were wrapping up the age 21 follow-up of our samples in Milwaukee, both our clinical and our control groups that had been followed up to that point for about 15 years. And we began to look outside the normal psychiatric and educational outcomes for these individuals, and we began to see that there were implications for their health that were occurring as we followed them into young adulthood. And at that point, based on very little data other than what we were seeing in a few earlier studies, I began to argue that there had to be an impact of what we were finding in the longitudinal studies on not just on life course and risk going forward, but on your actual life expectancy. How many years left do you have to survive? And so that led me to write up an editorial for my newsletter, the ADHD Report, and then to begin to study this in earnest the next time we saw these kids at age 27 to 32, when we did complete physical exams and lipid profiles and other measures of their health at that time. So why would we expect that life expectancy might be affected by this disorder? Well, you don't even have to go into the medical outcomes literature to be able to see what these implications are. You can see here that longitudinal studies as well as cross-sectional studies have documented numerous risks that place the individual at risk for injury, for illness, for increased medical concerns, not to mention for their life expectancy. So by implication, in one way or another, all of these disorders that we are seeing racking up over time in the lives of children might be expected to have some impact on your health, well-being, and probably on your life expectancy. So by the time a child reaches early adolescence, you don't have to be an insurance actuary to start to infer that if you were going to start to insure this person's life, as the insurance industry would do, you might well start to have some caveats or reservations about insuring the lives of these individuals. But of course, nobody at that point had directly examined that particular issue. And then as we followed our patients up into adulthood, as did many other studies, including the longest running study so far, which was the New York study, we began to see that by young adulthood, we were seeing lots of impacts on limited educational attainment, on peer relationship problems, family conflict, antisocial behavior, arrest rates, drug use, as Tim has already spoken about, occupational maladjustment, financial difficulties, poor credit, difficulties in intimate relationships with others, including intimate partner violence, which is directly predicted by ADHD, not just by conduct disorder and substance use disorders. And then following them further, we get into difficulties with, pardon me, with marital satisfaction. And then, as Andrea Cronus and Charlotte Johnston and many other people have begun to show, the disorder begins to impact your own ability to raise your children, whether or not they have ADHD. And of course, if they have ADHD as well, which they're much more likely to do given the genetic risk of the disorder, then we're going to see parenting even more disrupted by the fact that both people in that relationship have the same disorder. And then, as more recent studies have indicated, the longer your ADHD goes untreated, the greater the risk that you're going to develop an anxiety disorder alongside that ADHD going forward. And then a couple of studies in Sweden which have begun to focus on the status of elderly patients with ADHD demonstrate a growing risk for depression in that age, as well as loneliness and estrangement from one's extended family. So again, you don't have to be in the insurance industry to look at the totality of that picture and to realize that maybe this is going to take a toll on the life course and life expectancy of these individuals. Well, since writing that editorial and getting involved in this research, we've begun to see more direct evidence for an impact on life expectancy. First of all, I got interested in part because of Friedman's work with the termites, which is the follow-up of Terman's gifted and talented students in California. These individuals were followed over their entire life course and were periodically evaluated. And the study, of course, has the cause of death in all of these individuals. And what Friedman found is that the single best predictor of life expectancy, or death by all causes, is the childhood personality trait of conscientiousness, which is the opposite of impulsivity and which is incredibly low in individuals with ADHD. And this has now been subsequently verified in countless studies on predicting death in humans. Conscientiousness is a mediator of death by all other causes. And that's because low conscientious people are likely to be engaging in all of those other mediating events, such as substance use, smoking, diet, obesity, poor health care and health maintenance, and so on. And what Friedman found, and has been replicated, is that if you are in the bottom quartile of the human population in the personality trait of conscientiousness, you are going to have at least 7 to 8 years stripped off your average life expectancy. Now, given that figure, and that ADHD is the bottom 5% of the population, not the bottom quartile, it doesn't take a genius to extrapolate that into inferring that the life expectancy of people with this condition is going to be shortened by a lot more than 7 years. But again, it's all inferential from the existing data. Luckily, since the Friedman study and other longitudinal studies have been published, we're beginning to see large population studies about the likelihood of increased early mortality in various ADHD populations. And you can see here one study that was done back in 2009 looking at externalizing disorders, and that children with these disorders were 2 to 3 times, at least twice as likely to be dead by the age of 46 than were people without externalizing disorders. Now, granted, that lumps together oppositional conduct disorder and ADHD, but you begin to see again the implication that an externalizing disorder is placing your life at risk. And then we see from the Mayo Clinic studies, particularly Barbarese's study, of the growing risk, although non-significant in this follow-up study because they were just young adults, that there was a growing non-significant risk for early mortality, but especially a significant risk for suicide. And this has now been replicated in other studies as well. It is depression that increases your risk of ideation. It is impulsivity that increases the likelihood of an attempt. And as we found in the Milwaukee study, the presence of impulsivity increases an attempt by 4 times over the base rate of other depressed, non-impulsive people. So it is impulsivity that drives the attempt at suicide, whereas depression is really governing the ideation about suicide. And then more recently, we see about a year and a half ago, the study by London using a very large population sample indicating that ADHD was associated with nearly a doubling of the risk of mortality within the next 4-year period of following that population. And then most recently, from 2015 is the Dalsgaard study, again, using huge populations in Europe, particularly Sweden and Denmark, looking at life course risk for early mortality. And what you see here is that the risk doubles between childhood and adulthood, going from 1.86 risk of early mortality in children all the way up to, as you see here, 4.25 is your risk by the time you enter adulthood. And that makes perfect sense. You're entering into more domains of risk. You're more independent of supervision. You're able to engage in things that are more life-threatening, such as substance use, driving, perhaps risky employment, if not risky sports activity. All of these would start to take a toll on the likelihood that you might not be surviving as long as other people do. What that leaves us with, pardon me, is the question, so how long do you have left? This indicates that you have an increased mortality, but can we start to predict what your life expectancy is going to be? And this is very difficult to do because many insurance companies and others excuse me, who have these large databases are not necessarily willing to share their proprietary evidence. But the fact is now some of them have, and they've made them available to us publicly so that we can begin to take a look at calculation of life expectancy. Now, there are other reasons besides the data presented so far why we might expect a shortened life expectancy. We've talked about some of those already, but other those directly within the health realm have to do with the diet of these individuals, the poor medical hygiene, so to speak, or health maintenance practices, the fact that there's a growing risk for obesity, as well as frank eating disorders, particularly within females, that we see a greater likelihood, as Tim pointed out, of substance use and abuse. Our own Milwaukee study documented a growing risk for, pardon me, for abnormal lipid profiles, particularly with low HDL, high LDL, and the ratios being out of whack, such that if you use the Framingham predictors of future coronary heart disease risk, we were seeing a 5 to 10 times greater risk, even at age 27, that people with ADHD were going to have coronary heart disease. And then, of course, there's now more recent evidence on the growing risk for dementia, and one can infer, though it has yet to be demonstrated, that given the substance use alone, there's going to be a growing risk for cancer in these individuals. So let's take the data from the Milwaukee longitudinal study with my colleague Mary Ellen Fisher, and let's use the age 27 physical findings on these individuals, and then let's go into a publicly available life course and life expectancy prediction algorithm that's made available now by the University of Connecticut and see if we can predict what is the life expectancy of these individuals. In case you're not familiar with the Milwaukee study, we have been following 158 ADHD children well diagnosed in childhood with a control group of 81 children contemporaneously who were matched from the same neighborhoods, schools, and so on to the ADHD children. And at age 27, we divided our sample into those whose ADHD had persisted to that age. That is, they could be diagnosed using a developmental criterion, which is if you have 4 or more symptoms and impairment, you are deviant. By the way, notice that we didn't use the 6. Finally, DSM-4 or 5 rather caught up with us that when you're diagnosing adults, you need to be reducing the number of symptoms in order to maintain the developmental sensitivity of the DSM. And by the way, the studies indicate that it's not 5 symptoms, it's 4 that is the demarcation for statistical abnormality in the adult population. So when we apply a cutoff score that is developmentally appropriate for adults, we can determine who persisted, who didn't persist, and what is our control group. Then, using the University of Connecticut Life Expectancy Calculator at the Goldenson Center for Actuarial Research, which is now available publicly online at the web address that you see below, you can begin to enter in their search engine a variety, or in their calculator, a variety of factors that they have found to be related to life expectancy. We were surprised, by the way, to see that there are some things we thought might be on there that turned out not to be on there, such as your cholesterol panel. And it turns out that the reason it's not on there is it's entirely mediated by obesity. So there's no reason to enter your cholesterol if we know that your body mass index is already elevated. That tells you something, that people who are of normal weight but who may have unusual cholesterol panels may or may not be at risk for reduced life expectancy. It's the obese that really count. So what we did is we took our kids at the young adult follow-up and we began entering their mean data. So this is not entering the individual's data into the calculator. We haven't done that yet. We are doing that, but that is a very labor-intensive process. We simply took group means at this point and entered them into the calculator to see, as a group, what were we getting out of life expectancy. And you can see here that these were fixed variables that we entered for all subjects. In other words, the groups don't vary on the entry point for these. Now, you look at that and you say, well, what about the driving risk of these individuals? Unfortunately, in this calculator, unless you're having an accident per year, which is very unusual even in ADHD populations, that the calculator isn't taking that into consideration. Maybe they'll revise that later, but not right now. Then there were some variables that we adjusted by group because we already knew that they were statistically different from each other at outcome. So notice the difference in weight of the individuals at outcome. Notice the difference in diet. We collected self-reported information on nutritional concerns in our population, and of course these were related to group status. ADHD individuals reporting much more problems with their nutritional status than controls, so we coded those separately. Sleep was also another problem that was being reported by our population. No surprise, 40% of adults with ADHD have sleeping difficulties, so we coded our group somewhat differently on that variable as well. And then, of course, there were binary entry points that had to do with whether or not you graduated high school. And, of course, we entered those based on group membership. And current smoking, alcohol use, drinks per week, by the way, your diet, and then regular exercise. So I don't mean to belabor the methodology here because this is what you really came to see. If you enter all those data based on group averages, or in the case of categorical information, based on what was the majority endorsing within each group, we find that there's a nearly 20-year reduction in life expectancy going forward in ADHD individuals followed to adulthood. This was stunning. By the way, I only did these calculations about 10 days ago, and I sat slack-jawed in front of the computer when these reports started to come out. I seriously have to tell you, I did not expect the differences to be as dramatic as they were. You can see that the group over to the right, over here, is the non-persistent group. Their life expectancy is reduced even if their disorder isn't meeting developmental criteria for persistence of disorder over time. So there obviously is some impact of growing up with ADHD, even if you are no longer diagnosable for it. And then this is our control group followed over time. By the way, I want you to pay very close attention. This is not what year you're going to die. This is how many years left you have. So you have to add these numbers to age 27 in order to calculate what the mean life expectancy is for these individuals. And when you do that, you may recall that the population statistic for humans is somewhere around 74 to 76 for males, a little bit higher for females. But by the way, that includes infant mortality. What you really want to look at is if you make it to age 27, what is the typical human life expectancy? It's in your mid to late 80s, by the way. So once you strip out childhood and infant mortality, humans can be expected to, at least these days, live well into their 80s and so forth going forward. Or at least half of them can be expected to live that long. Obviously, these mean life expectancies don't apply to everybody. So what we're looking at here is that individuals with ADHD, and you can see here the difference between how many healthy years they have left and how many total years they have left, the difference being how many years the calculator predicts they're going to be very sick. They may not die, but they're going to be sick from what they're doing in their life. And you can see here that there's about 6 years difference in healthy years versus the total years, and that tells you the number of years that they're probably going to spend as unhealthy individuals. Now, this is typical life expectancy given the average data. We then went back and recoded what about people who are at least a standard deviation away from the mean on these variables. And in the case of categorical data, we simply shifted you over to the next category lower than that. So we're looking here at plus or minus 1 standard deviation at whatever direction the risk occurred. So we pushed up your weight by a standard deviation. We pushed up your drinking by that. So we were looking at individuals who were in the top 16% of the ADHD group. In other words, they're a standard deviation above even the average ADHD individual, trying to get a feel for what would be the greatest risk within this population of the most deviant individuals. And here you go. The difference between the, and by the way, we did this with the control group too, just as a comparison. So this is worst case controls against worst case ADHDs, and you can see the difference here is at least 10 years or more in this population. A little, by the way, it's identical for the persistent group. Isn't that interesting? The minute you introduce high risk factors, even into your non-persistent and control group, everybody's life expectancy starts to get questionable or at least shortened. And just to help you out, this is the last two slides collapsed together so that you can see in the blue are the average data, in the red are the worst case data, and now you can begin to see that if you take the worst case ADHD persistent or non-persistent cases relative to the typical case controls, you are looking at a 25-year reduction in life expectancy if you're in that top 14 to 16% of the ADHD group. In other words, if you're a worst case ADHD individual, you're in significant trouble. Now, of course, there are a number of limitations. I don't want to dwell on these too much because my time is short here and we want to leave some time for questions. But let's remember that we coded the averages for groups. We are now going back and individually entering every single subject's actual data into the calculator. By the way, there's no reason to expect that the results are going to be all that much different than from entering group averages into that. But that will at least allow us to do the more appropriate parametric statistics on the individual data as we group them together. So keep that in mind. We need to go back and do that. The second thing, of course, is our sample sizes are relatively small. They're clinic-referred samples, which means they're worse than community-derived samples would be. We would expect in a community sample that you would find that probably you wouldn't get quite as much a reduction in people who are not being referred, but through a community screen might have been identified as eligible to receive the diagnosis. And then, of course, our longitudinal study had very few females in it, so our data are specific to males. It's probably going to be a little bit less reduction in life expectancy if we are looking at females. And then, of course, the Milwaukee study, being a Midwest population, is a predominantly ethnically non-diverse group of individuals, predominantly white or European American in their origins. So with all of those caveats and others as well that I don't have time to go into, we can summarize this very first quick pass pilot study view of calculating life expectancy as follows. We know that ADHD is a disorder of self-regulation and certainly of executive functioning. We know that self-regulation is inversely correlated with the personality trait of conscientiousness. And we know that conscientiousness is the single best predictor of human life expectancy, of death by all causes. We've also seen that in many longitudinal studies, people with ADHD are prone to a variety of impairments as they grow up, many of which have some direct or indirect implications for their health and longevity going forward. And more recent studies have begun to document a growing risk within the area of medicine and health, as well as a growing risk for increased mortality over time, being nearly, if not more than 4 times that of the general population as these individuals enter adulthood. We have also shown then that these risk factors have some impact on your predicted years left to survive. In the case of typical people with ADHD, we are calculating at least a 19 to 20-year reduction in your life expectancy, being about 12 years if your ADHD does not persist. What does this mean? This is a serious public health problem. If that point hasn't been made before, when I believe it has by many of the other people who are in this room, it needs to be made again. We have to stop looking at ADHD as strictly a psychiatric condition that is governed only by the mental health profession, because in looking across all of these risk factors, primary care, family practice, GPs, and others, pediatricians, are dealing with ADHD, whether they recognize it or not, because they are dealing with the medical risks that are associated with this disorder. We also know that unrecognized and untreated ADHD will hamper, if not completely obliterate, your efforts to manage the medical condition if ADHD is the underlying problem that is helping to contribute to that risk for that medical condition. So if you're trying to treat people to quit smoking or give up alcohol or enter substance abuse detox programs or lose weight or deal with their cholesterol panels that are out of whack, any effort at self-change within medicine is going to be impacted by the existence of a self-regulation disorder. And clearly that self-regulation disorder needs to be treated first before you attempt to deal with the overriding medical issue that is of such great concern to you. Because as Tim has pointed out, and many others, if you do not deal with that, the likelihood that you are going to rehabilitate this individual is dramatically lower, if not zero, than if you had diagnosed and treated the underlying ADHD first. So we know that under-recognition of ADHD is a major problem within the adult population in particular, and we know that it's even more of a problem outside the mental health community within general practice and family medicine and so on. And yet we know, as Tim has pointed out and many others, that ADHD is the most treatable psychiatric disorder known, that our medicines and our treatments achieve 2 to 3 times more change in at least twice as many individuals going forward, and with more treatments available to deal with this than any other outpatient psychiatric disorder. So that we should not be seeing these data that we are seeing here, given the availability that we have of treatment. The problem is that the population isn't accessing it. When they do access it, they're not adhering to it. They're not persisting in their interventions through those critical adolescent years, which I think was Tim's point, one of his many points anyway. And we find that they're not able to get these services reliably, particularly internationally, in the adult years. So the problem isn't that we don't have treatments for this. We have treatments that would be expected to alter the life course of these individuals, whether it's reduction of substance use, whether it's improving their driving, whether it's improving their risk for accidental injury in childhood or adulthood. We already have population data showing that ADHD medications reduce those risks to treated individuals. So again, the issue here isn't let's go out and we need to find more treatment. The issue is we need to start treating the people that are already there who are not accessing treatment and for whatever reason are not adhering to that treatment when they do access it. Thank you very much. Thank you. So there you go, the first time anybody had the guts to put a number on it. How long are you going to live, right?
Russ, thank you. That was
Thanks,
really
Brooke.
appreciate your hard work on diving into this so recently before the meeting. In 2002, you had a great paper that showed that the children that many of us follow in our longitudinal studies struggled with their insight.
Yes.
And now multiple people, Betsy Hoza, the PALS study in Pittsburgh, the MTA, have all been showing this. In the longitudinal child clinic samples. I think the jury is out with regard to adult self-diagnosis. That's kind of a different animal. What impact do you think the lack of insight issue might have on the data you just presented?
Well, to the extent that the data are self-reported, I think that it clearly has some impact. But let me differentiate here. What the research shows is that the underreporting of symptoms is most common below age 27 to 32, that by the time they reach their 30s, the reliability of their self-reported information begins to approach the same degree of correlation with other reports as we would see in the typical population. So there's a growing awareness over time. It takes about 3 decades for them to get there, but prior to that, they are prone to underreporting of symptoms and impairments in the area of externalizing symptomatology, not in the area of internalizing. As you know, internalizing the self-report beats the other report in terms of its veracity. But in externalizing, it reverses. So
yeah,
to the extent
we're even finding some differences in the finances and reporting in that older age range. So
right.
I think my point is, your findings are extremely important, and they could be even more extreme
Yes,
at
yes.
some level
Right.
because of underreporting of diet,
Absolutely.
exercise, sleep, et cetera.
Yes, that's right. That's right. We did obtain other reports, by the way, but you're absolutely correct. And also, you know, a good portion of those data were obtained from the physical exam or just from records about, you know, age, education. We have their transcripts and their school reports, their driving records. So we didn't just take, we have about 10 different archival databases that we tapped into to get information because of the problem with self-reports that you bring up, Brooke. So thank you for calling attention to that, because it means that, as you say, these results may well be worse than the ones that we're reporting here because of the self-report problem. But thank you. That's great. Margaret?
I was wondering, when you enter the individual data into the calculator, whether it might not be possible to look at those individuals who were resilient and had better outcomes to find out what their characteristics or protective factors were.
Sure, sure. I would be happy to do that. We can already assume that, knowing how the calculator categorizes information, that people who are toward the lower risk of those factors obviously are going to be the people with greater life expectancy. But there would be other variables we might want to look at, such as 80% of these people receive treatment for at least 3 years or longer in childhood. Is that related to life expectancy? I'm going to steal my own thunder and tell you I don't think so, because we found treatment was totally unrelated to any outcome in our study, because it's primarily childhood-limited intervention. Just as the MTA study found, just as every longitudinal study finds, when you start to move into adolescence, 3/4 of your sample starts to non-adhere to any available treatment program. By the time you hit age 21 to 27, that figure is well below 10%. So these people, as they get older, are opting out of treatment that they may have been getting when they were children. Consequently, as Tim has already pointed out, you're not going to see any relationship, or you might even see a negative relationship between treatment and outcome, which is, by the way, what we found for special education. The more you got, the worse you turned out. But Tim already explained the reason for that. Those are worse people to begin with. But it's a good point, and hopefully we'll be able to look at some of these predictive factors as we enter the individual data. We can't do that with group average data.
Take just one more question.
Okay, we just have one more question, so we go to the back mic.
Russ,
Alan.
I'd like you to put your clinical hat on for a second.
Yes.
Because I can't figure out if this is good news or bad news. And with that said, I'm sure you're aware that, you know, what you tell children and middle, you know, teens, adolescents, adults is different. And, you know, for 32 years, I've dealt with a normal distribution of parents who are terrified by treating ADHD. And I have to use every bit of ammunition I can to convince them this is a real, serious problem.
Yes.
And so my question for you is, in the middle zone, where parents, hey, they come to you, they're open, is this appropriate information to give to parents? I mean, if it was obesity, it wouldn't be a question.
Right.
But is this gonna, should we be discussing this with parents who are sort of in the middle? Because I'm gonna talk, I have those parents who aren't gonna put their kid on medicine. I'm gonna tell them about this.
Yes.
But for the middle group of people, what do you think about this news?
Well, as a clinician, I'll tell you what I did do up until a few years ago when I stopped practicing, and that is that because the bias of people coming into the clinic was against intervention, against diagnosis, this was a myth. You know, our antagonists in this hotel have done a fairly good job of convincing the media that we are dealing with a fairly trivial, non-existent, mythological problem that we all invented for the sake of the pharmaceutical industry. And so these are the biases that people have come in having read Alan Schwartz's book and, you know, Peter Bregan and all these other, you know, popular writers. So to me, I go the other direction. And I have been accused by other support associations of pathologizing ADHD too much. But it's because we have this incredible media bias against the seriousness of this disorder. I often call it the Rodney Dangerfield of psychiatry. It gets no respect when compared to bipolar or schizophrenia, all these dramatic and more severe conditions, and yet this is just as severe, if not more severe a condition than, for instance, some of those, and including, you know, the mild to moderate autistic spectrum. So I err on the side of, I want to scare the hell out of you. I want you treating this patient. And I don't want you equivocating. I want you to know going in what your risks are if you opt out of the available treatments, particularly opting out of medication, which many families try to do. Because that's my job. My job isn't to be your friend. It isn't to make nice. It isn't to convince you that you have a gift. My job is to convince you that you had better be in treatment and take this seriously. So I will err on the side of over-pathologizing to some extent, because how are you going to get the attention of the medical community, the public health community, Congress, the Social Security, IDEA 504? These people are not going to provide services on the public dime for gifts. We have to convince them that we are dealing with something that has a very significant impact and is a cost to society if it is untreated. And I even take that down to the individual level. So, criticize me for doing it if you will, but I scare people. You had better get this kid treated. Yeah. So, okay, that said, thank you very much.
Thank you. Great. Our last speaker tonight is Brian D'Onofrio. He is a professor and director of the clinical training in the Department of Psychological and Brain Sciences at Indiana University in Bloomington, Indiana. He received his doctorate from the University of Virginia after completing a clinical internship at the Children's Hospital of Boston, Harvard Medical School. I've heard of that place. His research focuses on the cause and treatments of psychological disorders using large data sets and advanced epidemiologic methods. I've followed his work closely. I think it's incredible work that he's been doing. He's worked with several international research teams. He's received funding from a lot of NIH-funded agencies as well as private foundations. And it's my pleasure to introduce Brian. Just in terms of structure, I think at the end of Brian's talk, he'll take a couple of questions, but then maybe all the speakers will come to the podium and we can have some time for further questions of anybody who's spoken today. All right, thank you.
Well, thank you for the invitation. This is my first time at this conference, and so far it's been absolutely amazing, particularly as a researcher and as a clinician, as a director of clinical training of a clinical psychology program. The emphasis on research, clinical work, and dissemination is absolutely critical. So thank you again for the invitation. I'm going to talk about large-scale data. But first, this is big team science. This is done in collaborations with lots of people, including world-renowned experts in psychiatric epidemiology, biostatistics. A lot of this work is done with Paul Lichtenstein and Henrik Larsen at the Karolinska Institute. I do want to point out I do have funding to support this from NIH and private foundations. I have explicitly made decisions. I have no financial conflicts of interest. So I'm going to quickly talk about what I mean by translational epidemiology. This might be a term that might be new to people in the audience. I'm going to particularly emphasize the importance of using advanced research designs, especially when you want to make causal inferences when you have not been able to randomize people. I'm then going to talk about our research in the United States on substance use problems and motor vehicle accidents, really trying to address major public health concerns. And then I'll quickly summarize some of our other findings on other outcomes. And then I want to review and really talk explicitly about what this means in terms of clinical implications. So first, there was a paper written by Michael Rawlins in Lancet. And what he talked about is how do we, as either clinicians or medical groups, make decisions about what types of interventions we provide. And what he pointed out is that there are some large research groups that have a hierarchy of what you should base your decisions on. At the lowest, it's expert opinion, and at the highest, it's the systematic review of our CTs. Okay? Now, certainly there's a hierarchy, but what he points out is that the notion that you can always reliably put research in a hierarchy, it's just impossible. In fact, there are different research groups that come out with different lists. And one of the reasons is that there are major limitations of randomized controlled trials. Randomized controlled trials are wonderful. You have great internal validity, the ability to say that the exposure caused the outcome. But you cannot study rare but very serious outcomes. So when we're looking at, for example, drug overdoses or major motor vehicle accidents or traumatic brain injury, You can't study that in a randomized controlled trial. They're just not large enough. Then there are concerns about generalizability. Well, what are the patients who actually end up in randomized controlled trials? In some of our data, when we're looking at suicide, for example, the highest period of risk is actually the couple of months before they are dispensed an ADHD medication. These people don't end up in randomized controlled trials. Ethically, you can't. And then there's, well, what about the generalizability of the dose or the timing or the duration of therapy? You can't randomize people for 10 years. Then there's settings. You know, if it's in a highly controlled university setting, what happens when you put it out in the community? In terms of most of our psychosocial interventions, there's a voltage drop. So there's a huge question about rare outcomes and generalizability. So, well, how do we proceed? And there's been a growing movement in lots of fields of medicine to rely on large-scale data. You know, big data is really sexy. You know, can we use large-scale data sets that perhaps weren't collected for research purposes to try to answer important public health questions? But how do we make causal inferences when we don't randomize? Okay? And one of the keys is that if you have an exposure and it's associated with an outcome, you need to rule out all plausible alternative explanations. And generally what people do is use statistics. They use covariates. They try to match people. For example, they'll use propensity scores, or they'll factor out other things. But there's been some major reviews, and this is a great review. We're terrible at this. We're absolutely terrible for two reasons. One is we're never sure if we actually measured the key constructs. And what this paper highlights is even if we measured them, there's tons of measurement error in those variables. We do not control very well when we use statistical covariates. So in lots of fields, and this is just one book that I actually make lots of my students read, is the importance of thinking about research designs and the primacy of thinking about designs instead of just using statistical covariates. Now, each method, each design is going to have limitations and assumptions, so of course you're going to need converging evidence from multiple designs to really strengthen a causal inference. So we've done lots of work using designs that help account for confounding factors that we don't measure. So Anita is going to actually talk tomorrow about if you use different designs, for example, in prenatal risk factors for ADHD, you get different answers than if you just use statistical covariates. So this is a movement called translational epidemiology. You can sarcastically think that you just put the word translational in front of epidemiology so you get NIH funding. But I think one hope that I have is that by the end of this talk, I have convinced you that there's an important role for large-scale data and epidemiology in answering questions that have direct clinical relevance for what people do tomorrow in their practice. So let's talk about ADHD medication. I'm going to quickly go through this. We had great plenary last night. People earlier have already talked about this. Randomized controlled trials we know have short-term effects, particularly for the core features of ADHD. But there are still very serious concerns about concomitant, so co-occurring, and long-term problems, like substance use problems. So for example, in the mainstream media, there's been lots of attention that ADHD medication causes substance use problems. Well, major reviews, do stimulants actually cause this? Well, this is not a very satisfactory answer if you are a clinician. Maybe. There have also been very controversial reviews. So I think the literature, there's not necessarily a consensus, certainly outside of this room. But randomized controlled trials, as I've highlighted, cannot understand rare and serious outcomes, and there have been recent reviews. We don't know about the risks and benefits, particularly for these outcomes. But in observational studies, and other people have pointed this out, medication is associated with bad outcomes. And in epidemiology, this is the concern of something called confounding by indication. Is the medication causing the outcome, or is it the underlying condition for which you are receiving the medication? And so our research program is trying to use the best designs to rule out confounding by indication. So I'm going to present to you some large-scale analyses using a United States data set. I'll then summarize our Swedish studies. We're using the market scan data set. This is owned by Truven Health, which is now part of IBM Health. This is taking health insurance claims. And what they have done is taken about 100 large health insurance companies. So we have their employees, the spouses, dependents, everyone who's covered, and we will look at their claims. Now, this is big data in the sense that between 2005 and 2014, roughly 150 million people are in here. Just in terms of demographics, in 2013, 51% are female, 78% have drug coverage. What's important, and I want to highlight, is that this is health insurance claims. If you switch jobs and move to a different insurer, we lose you. If you lose your job and you lose your insurance, we lose you. So we have different people covered for different periods of time. This is one of the reasons why I like doing research in Sweden. There's only one insurer, so we follow you forever. But we're going to use a design called within individual comparison. So we're going to use the same individual as the comparison group. So we're not going to compare some people who are exposed to medication to unrelated people who are not. What we're going to do is say, what is the risk of serious outcomes in an individual when they are dispensed their medication versus the same individual when they are not dispensed their medication? This takes into account all factors that are stable over time. Now, certainly, as a developmental scientist, I know that things change over time. So what we also do is add statistical covariates for what we refer to as time-varying confounds, so things that will change over time, okay? So just to summarize, or just to give you some details, we're now looking at 3 million people with a diagnosis of ADHD using this data set. It's great. We don't have to think about p-values ever. Our exposure are dispensed medications. We're mostly looking at amphetamines and methylphenidate. The outcome, we need a very time-specific index. So we are looking at emergency room claims for a substance use problem. This means that you end up in the emergency room and you are diagnosed with the substance use problems. We're capturing things like major overdoses. And the methods that we're going to do are two main ones. One is within individual, what's happening in the month in which you had your ADHD medication versus months you weren't. And then we're also going to look at, quote, long term, and our long term is 2 to 3 years, okay? So now to orient you, I'm going to show you lots of results using this type of diagram, and we've already talked about this. This is an odds ratio, so an odds ratio of 1 would be that there's no increased risk. To the right is going to say that there's increased risk, and to the left that there's decreased risk. So the first thing that we did is we just compared people with ADHD to match people who do not have ADHD and say, okay, is ADHD associated with these rare but serious emergency room visits? And you can see that for both males and females, by the way, the confidence intervals are shown. You just can't see them, they're so small. But in terms of absolute risk, males, 3% of them had an emergency room visit over this 6-year period, compared to 1.2%. For females, it's 2.5 to roughly 0.8%. I highlight this to show that randomized controlled trials, you can't study these rare outcomes. So the next thing we did is say, okay, we're only going to look within ADHD patients. And we're going to say, okay, for the people who had medication versus the people who don't, is medication associated with greater risk or less risk? And it's actually associated with a smaller risk or a reduced risk. Now, this could be due to lots of explanations. This could, in fact, be due to people do not prescribe ADHD medication to people with substance use problems. So the key thing is, what happens in the months in which a person is dispensed their medication compared to the same individual when they don't have their medication? And you can see that ADHD medication is associated with reduced odds. So, to be explicit, for males, they were 35%, the odds were reduced 35% during the months in which they were dispensed a medication versus when they were not. That is a huge reduction. Now, there are questions about, well, does this depend on the population? So we said, okay, we're going to take all people with a previous diagnosis of a substance use disorder, okay? So is mostly these stimulants, is this associated with increased risk or decreased risk? And you can see that even in this subgroup, it's associated with decreased risk. Well, what about different age periods, okay? So from 13 to 17, the youngest range, all the way up into adulthood. And we can see that it really doesn't matter. It's associated with decreased odds in all of the different age groups, okay? Now, this is observational data. There can be lots of different explanations for why there could be reduced risks. And in big data, you can actually do some really cool things to help rule out alternative explanations for these findings. So first we wanted to say, okay, is this due to other psychiatric medications? Okay? People brought up, well, is this just monitoring? Okay? And in fact, most people are actually now getting multiple medications. So we said, okay, we're only going to look at people who only got ADHD medication. So we removed people with antidepressants, anxiolytics, anti-epileptics. And in that group, you still get a reduced odds. Well, is this just getting treatment in general? So we said, okay, what about people who didn't get any psychotherapy? There's reduced odds. What about what's referred to as an incident diagnosis cohort? We're going to actually take people who've gone a year without any ADHD medication, and so these are new, at least onset, dispensations. It's still associated with decreased risk. Well, what about only looking at first events? Especially in adults, why are you going to get dispensed medication? It's mostly because there's been a major precipitating factor. This suggests that some of our findings may actually be conservative. Well, we don't know if people took their medication. We're not in their house, okay? And so sometimes people have extra medications. So we're going to say, okay, what happens if we just assume the month after they shouldn't have had their medication, they still have it? Doesn't matter. What about stimulants only? Of course, the concern for substance use problem is not atomoxetine, it's the stimulants. You get the same pattern of findings. Well, is this due to some reason of how we've actually indexed the outcome? So we actually expanded it and said we're going to take ambulance visits, inpatient visits, and emergency room visits. And you don't see any difference. We then said, can we use a different medication? So we looked at SSRIs. This in some ways is what's referred to as a negative control. It has some of the similar selection factors. People are going in because they're having mental health problems. So do you get the same pattern? And no, you don't. Antidepressants is actually associated with increased risk. Now, we do not think that antidepressants actually cause these. We think that the time-varying factors are very different. The key for this audience, though, is that you get a different pattern for antidepressants. Well, what about the association 2 years later? So we're now taking an interval. What is your exposure here associated with substance use problem 2 years later? It's still associated, even when controlling for your medication use in that month. What about cumulatively, the number of months in the previous 2 years? Okay? Each month is associated with decreased odds. And do you get the same pattern of findings for SSRIs? Well, in fact, you don't. SSRIs are not associated with reduced substance use problems indexed by an emergency room visit 2 years later. Okay? I think the key, in terms of visually, everything is to the left. ADHD medication is associated with fewer odds. Now we wanted to look at major motor vehicle accidents. A lot of people, including some of our colleagues, have said, is this just people getting their act together? Is this just people making decisions to get their life together, and it has nothing to do with the ADHD medication? Well, what about outcomes through which that might not actually, those sorts of factors wouldn't play a role? So we looked at motor vehicle accidents. We now have 2.3 million people because you have to be old enough to drive. Again, we're doing dispensed medications, mostly amphetamine and methylphenidate. And now we're doing emergency room visits for a car accident. We're going to do the exact same analyses. I'm not going to show you all the sensitivity results, but I'm going to walk you through these findings. So first, do ADHD patients, are they more likely to have major motor vehicle accidents compared to people without ADHD? Yes, of course they are. But what happens when you look within individuals? What happens in the months in which they're dispensed medication compared to when they're not? They are at reduced odds. About a 40% reduction in the odds of a motor vehicle accident in which you're going to end up in the emergency room. If you just look at first events, you get the same pattern. So this isn't people get into a major motor vehicle accident and then they get their ADHD medication and you're looking at something after. This is for the first motor vehicle accident. Do you get the same pattern for antidepressants? Not really. It's associated with a decreased risk, but it's not explaining all of the association. And what happens long-term, 2 years later? 2 years later, even controlling for medication use in that month, medication is associated with decreased odds. Now, there are other studies that we have done. I don't have time to go through them. We have a paper in press with seizures. My graduate student actually has a data blitz at 1:15 in poster session number 75. Please go talk with Kelsey. This has major implications for people who have seizures. Do stimulants actually increase the seizure threshold? Well, I'll let you go to her talk. Okay, in Sweden, everything that happens to you in Sweden is put into a data set. And so we can combine these, including their prescriptions. So we have done research on substance use problems, motor vehicle accidents, suicidal behavior, depression, criminality, school achievement. One of my colleagues, his graduate student, is actually presenting in the data blitz at 1:10. So in 10 minutes, you can get both US and Swedish findings this afternoon, poster session number 64. Okay, but to quickly summarize the in-press papers in Sweden, for substance use problems, what happens when people are on their medication versus not? It's associated with decreased odds of substance use problems. For motor vehicle accidents, for males, it's associated with decreased odds. For females, we actually just didn't have the statistical power. We've updated our data set, and in fact, it's protective for them in the new data. What about suicide? We talked about impulsivity associated with it. It's associated with decreased odds of suicide when you're on your medication versus not. We've actually, preliminary analyses in the US data set suggest similar findings. Well, what about onset of new depression? It's associated with decreased odds of depression. Well, what about criminality? This is the Paul Lichtenstein article. What happens when people are on their medication versus off? They are less likely to engage in a crime in which they're convicted during those periods. And recently, after release from prison, prisoners who are released are less likely to engage in criminal activity during the periods in which they're dispensed their medication than when they're off. So let me summarize. I think the studies from within individuals, I think that this should mitigate and help mitigate concerns about rare but serious outcomes like suicide, substance use problems, and seizures. They also might highlight protective effects that are consistent with randomized controlled trials, like criminal activities and motor vehicle accidents. There are also lots on accidental injuries in children. In fact, we have some results suggesting that ADHD medication reduces the odds of having a major traumatic brain injury. And these are serious public health problems. And at least our initial analyses show that these might apply to even at-risk populations, people with previous substance use problems, people who are in prison. There are lots of limitations. Okay, I can't say that ADHD medication causes these outcomes. We are not randomizing them. There are lots of things that can change over time. There are also measurement concerns. Again, we are not in the house watching them take their pills. So in terms of randomized controlled trials, this is similar to an intent to treat analysis. We're also looking at really serious events. So for example, for the motor vehicle accidents, this is motor vehicle accidents where you end up in an emergency room. Well, what happens for a fender bender when you don't? For seizures, you have to end up in an emergency room. Okay? There's also questions about generalizability. Now it's great, we're getting the same pattern of findings in Sweden, which has a very different healthcare system, social network, all of that. They're also more conservative in terms of who gets diagnosed and treated. We're replicating from there to the United States and the market scan. But again, the market scan is people with private insurance. Okay? So I've had lots of conversations with the CDC. Can we actually look at the Medicaid population, for example? And I say long-term effects. And these long-term are 2 to 3 years. Okay? As a clinician, like long-term for most people means, you know, if I start medicating my kid when they're 7 or 8, what's going to happen when they're 18, when they're 25? I still think that there are questions about that, although that there's data to suggest that. And we also haven't looked at all possible iatrogenic effects. What are the clinical implications? I want to raise the possibility that there may be risk associated with not prescribing. Okay? We generally think about errors of commission. Well, what about errors of omission? okay? Especially with people who have severe ADHD, okay? We just had a talk. There are serious public health outcomes. These people are much more likely to have huge accidents and injuries, traumatic brain injury, okay? Are there concerns that we might not be medicating people when they should be? And a lot of these studies are looking at adolescent and adult outcomes, okay? Most of the studies, understandably, have been focused on children. I think that this is important in terms of what are the implications of medication for adults. So we joke, should we put this in the water? Well, there are other side effects that are really important to think about. By the way, lots of people use this joke, but literally as we said that in the room, I looked around and we were all holding coffee or tea. Like, in many ways, it is in the water. But there's also, of course, very well replicated results looking at effects like on stature. There are sleep problems. And there are huge problems with diversion, okay? I can walk across the street to the library at Indiana University, and I can get a stimulant to help me get through finals. Meta messages. Hopefully I've convinced you that large-scale observational studies can inform, in this case, applied research. I also think that it can inform basic research. For my colleagues who are studying seizures, what is it about ADHD medication that may be associated with that? Without the ability to randomize, researchers really need to think about designs. Covariates are not enough, okay? My whole research career has been basically trying to test different theories. Some theories hold up, but we've actually shown that lots of things that people think are causal really aren't. And I think that these studies can really help guidelines and practices and people helping to weigh the risks and benefits of different medications. I am not saying that we should medicate every single kid, okay? But when you're sitting down and working with a family, okay, and they say, I'm concerned that ADHD medication is going to change their brain, my general response is, well, eating a cheese puff changes their brain. The question is, how would it change their brain? Is this a good change? Is this a bad change? And I think these large-scale studies, in combination with smaller randomized controlled trials and other research designs, can really help us understand what are the risks and what are the benefits of these medications. So thank you.
We'll take questions for Dr. D'Onofrio and also for the other speakers if Tim and Russell want to come up also, but we'll start.
Hi, this question is for you. Thank you very much. It's very interesting, the data you showed. When you looked at substance use disorders, did you separate into stimulant use disorders? It appears that there's a little difference in terms of people with addictions and what they choose to use.
Yeah, that's a great question, and no, we didn't. We tried to look at it, but we also talked with people in emergency rooms. Most of the time that you show up in an emergency room for things like an overdose, it's not just one medication. Mm-hmm. And so most of the time this is polydrug problems, and so we are not confident. And this is one of the limitations of secondary data analysis. We don't have the precision of measurement to know, okay, is this a stimulant overdose, or is this due to something else? So unfortunately, we don't have that detail.
And a quick second question. Did you also look specifically at pregnant patients?
That's a great question. We have a huge research program looking at pregnancy-related risk factors and mother's medication use during pregnancy. There we use different designs where we will compare siblings where one is exposed and one isn't. At least in Sweden, we don't have enough power to look at ADHD medication, but we have looked at things like antidepressants used during pregnancy for ADHD and autism and those sorts of things. So it's something that we're looking at pursuing specifically for ADHD medication in the future.
Great presentation, thanks. And it works so well with...
We're surprised.
No, exactly. No, not the treatment. It works so well with the program because we're having another session on technology and big data and things like that. So this is one of the themes of the meeting, which is great. But I have a methodologic question to ask, actually, which is, This is a perfect design, you know, your time on and time off drug for stimulants. And you have your SSRI comparison, but how would you do it with other drugs? It's not as clean.
No, it is not. And so the nice thing about ADHD medication is that you take it and it works and it gets out of your system. We have a large research program looking at antidepressants related to suicide. And there you have to think very carefully because, well, yeah, they're taking the medication, but the therapeutic effect is going to take a while. What's interesting, at least preliminarily, just for those in child psychiatry, the period of greatest risk for suicide is actually the couple of months before they get put on an antidepressant. In our data, it doesn't suggest that antidepressants are as protective in child and adolescents as they are in adults, but it is nowhere close to being associated with increased risk of suicide. But absolutely, you have to think differently about which exposure you're looking at based on the different pharmacological effects.
But I mean, other than asking the questions in a way that lines up properly with what you're studying, are there analytic approaches that have to be varied for different kinds of drugs with different temporal courses and things of that sort?
Yes, absolutely.
I have a sociological question for Russ. I was going to just ask you personally afterward, but since there weren't a lot of questions going on, you're finding...
That scares me that you're making it a personal question. So. Go ahead.
Okay. So your finding of shortened life expectancy, in my view, in my lifetime as a researcher, is profound. I mean, this is a big finding. And, you know, the usual way big findings get rolled out, there's a press release by the New England Journal of Medicine, and it's, you know, on the front page for a couple of days. But I guess my question for you is, have you given any special thought about how to, and I'm going to use a cliche, roll out this finding? Now, I have an idea it's going to be in the ADHD report, which is not the New England Journal.
No.
But it's kind of like obesity. We don't have to tell parents who come into our offices that their really obese kid is going to have 6 medical problems and die earlier. I mean, that's common knowledge. And so the question is, you know, how are we going to get this to become common knowledge? And it's more sociology than science.
Yeah, and politics. And honestly, the answer is no, I hadn't thought about it. The idea for this presentation only came up over the summer months when I approached the board. And we didn't even look at the data until, as I said, about 10 days ago. I think because we're more concerned that we go back and do the study correctly by coding every individual within the data set before we roll this out, because it can be methodologically challenged the way I presented it here. That's why I emphasize it's a pilot first pass to calculate an effect. I think once we go back and do it correctly so that it can withstand some scrutiny and review, then the next issue is how do you announce that to the public? So I don't know, Alan. I mean, I'm sure other people have better ideas than I. Marketing's not my strong suit. Yeah. But thank you. Yeah.
Hello, my name's Jake Behrens. I'm actually coming to you from Milwaukee, and I had no idea that data actually came from the city where I'm coming from, as in Wisconsin, it's a very managed care state with a lot of, I'd say, professional stigma against ADHD specifically.
Yes.
That's what I've been battling since residency in the faculty in Madison, University of Wisconsin. And so much of it comes from the narrative that been trying to change is we see everyone talks about the risks of medicating, or the risks of diversion, the risk of abuse, but no one's talking about the risk of underdiagnosis, undertreatment. I think that's a narrative that, I don't know if the organization here, it's my first meeting, happy to be out here, about how we address that. And then two, I think as we get into this in the Milwaukee Journal Sentinel, is big reports there where they are trying to put this as huge amounts of substance abuse, which no one defines substance abuse as a survey where you go to the library and ask a kid if they've ever used an unprescribed medication. That's substance misuse, not abuse. But what I'm seeing is this narrative where they take data about increased ER visits by amphetamine use across the country, and they're looking at methamphetamine and not discerning by the type of medication done.
Yes.
Are there any concerted efforts here for how to address this in our own local communities?
Yeah. I just want to say, because I'm an addiction psychiatrist, I deal with this all the time regarding if people know about buprenorphine or methadone, and that this is always the argument by people who are against buprenorphine for opiate addiction, is that it's going to get diverted. And it's such a small problem compared to overdoses and deaths and the fentanyl epidemic, that the fact that still there are DEA visits on doctors who are appropriately prescribing buprenorphine to keep to people prescribing down is a big issue. So I see the same problem from the other side in terms of addiction and not prescribing buprenorphine, or even people not wanting people to go for methadone. The thing that has galvanized or changed the attitude, and where finally senators are coming out and saying people should be on buprenorphine if they have an opiate dependence, is all these deaths. So as Russell was talking about length of life being reduced and life expectancy, I think that's a dramatic finding. I don't know whether we can say being on ADHD meds lifelong is going to change that. We don't have that data. But I mean, it's sort of similar that unless it's seen as an enormous public health problem, then people say, okay, maybe we can put up with, quote, a little bit of diversion in order to get more people being adequately treated. Yeah. So I see that parallel. That's probably why I do both types of research.
I think that's the unique thing there is if you look at all of psychiatry, the only two medications we have that have, above a 0.5 effect size are stimulants for ADHD and buprenorphine for opiate use disorder, yet they're the two most difficult to obtain or to prescribe medications.
Right. People don't like agonist treatment.
Yeah, I was going to say, as psychiatrists, we like to analyze things, not actually fix or treat things.
Right.
Okay, thank you.
Brian, did you have something
more of a comment than the question? So I think when Dr. Wilens commented about the monitoring, and that's very important, and it's also important to have that initial baseline restratification. And just give you an example of a case that we actually treated at the Mayo Clinic Intensive Addiction Program. The patient was self-referred from here and was treated by 2 independent psychiatrists for ADHD, and the medications were filled by 2 pharmacy. He was given 420 milligram of Wilens and 240 milligram of Adderall, along with Pristique, bupropion, and Xanax. He has a son who had an overdose on drugs and died. Family history of addiction was there. And he was treated with those medications for 8 years before he self-referred himself to our Rochester program and stayed there for a month. So I think that the baseline restratification was not done and properly monitoring was not done. And I treat ADHD a lot in addiction population, but this is something very important, that you cannot just give prescription and don't monitor it, don't restratify the patient, and give them 3 months supply and never check the urine and things like that.
Yeah, I would agree, and I probably would recommend not giving 8 of the highest dose Wilens tablets a day at one time. That's probably not what I do clinically. So.
No?
Yeah, so he was on 400% of the dose in both Adderall and Wilens.
Yeah. Please introduce yourself when you give your question.
Okay, hi, I'm Tony Rostein. Thank you all for a wonderful panel. Tim, this new interest in the opioid epidemic, and any of you, are you looking at the existence of ADHD in those individuals who are becoming more prone to becoming opiate addicted? Because there's this partly, and I'm going to ask Fran to join in because I really want your wisdom on this. You're a leader in thinking about not being afraid in the substance use field of treating ADHD and using stimulants. But part of the problem is everybody wants to put these in different silos. Right. And of course, not only is it the stigma that you're harming people by treating them, but what we're really missing is what's at root in the other studies that you reported, is that this is a harmful dysfunction, this harmful trait that grows up and accompanies people throughout life and manifests itself differently. But I wanted to get back to this, since everybody's paying attention to the opiate epidemic. Is anybody looking at ADHD, and can you help us understand that?
Ryan, go ahead.
Yeah, we have a lot of data on that. We have a grant. My postdoc, Patrick Quinn, I wanted him to be here, but he's on a job interview. So we've looked at this in the large health insurance claims data set that I presented. And what's really interesting, this is both for adults and for children and adolescents, there's this notion of adverse selection. So the people who are at most risk for having problems with opioids are the people who are most likely to get opioids and to get the highest dosage, and they're most likely to be on long-term opioid analgesic therapy. So for example, in our data set, we took people who went a year without being on opioids and looked at what are the predictors of who's going to just get an opioid, and lots of psychiatric factors predicted just a little bit. But if you look at who's getting the highest doses and who's getting treatment for over 3 months, ADHD, substance use problems, suicide attempts, previous dispensations of benzodiazepines, all of these things predict who's going to get opioids. And this, I mean, you don't want people having opioids and benzodiazepines. That's a really bad combination. All of these people were excluded from randomized controlled trials, but the people most likely to get the highest doses, and this is not new to people who know about ADHD and psychopathology. So if we want to understand what are the risks of opioids, we also have to really understand, well, who's actually getting them? And this has huge implications in terms of, I think, one, how you treat pain, especially in a developmental context, thinking through how do we best assess and care for these individuals.
Yeah.
But
the other thing I would add is that there were studies in the 1990s in methadone programs that about 17 or 18%, 20% have ADHD. So people coming in for treatment for opiate dependence, maybe as a result of prescription opiate use or not, have elevated rates of ADHD. And my experience is most substance abuse treatment programs, like I said earlier, aren't identifying. They don't think it's a big problem. They're focused on depression. They're doing what they absolutely have to, is ask about suicide. Do they have schizophrenia, so they shouldn't be there? But they don't ask about ADHD in any real way. What I'd recommend to people, because it's a different audience, is something called the Providers Clinical Support System, PCSS.org. I'm the medical director of this program, and it provides training in opiate treatments, medication-assisted treatments, and pain prescription and how to deal with that. It's a wonderful resource. Millions of dollars by SAMHSA was given to it. All the data, 2,000 organizations that are allowed to train in buprenorphine training are involved in it. It's called PCSS. I did a module with our fellow on opiates and psychopathology, and one of the cases in it was somebody with ADHD, because I wanted that in there. So if you can look at that, if you have patients who have problems with opiate addiction, it's a good starting point. So PCSS, I'm giving a plug for that.
One of the things we found, we have a faculty member, Amy Ewell, who's here, I think, and she's looked at this issue of ADHD and opioid use disorders in young people, and she's really focused on that, looking at that now. But one of the first cuts was, does ADHD increase the risk for overdose in that population? We have a young person addiction service, 16 to 26. We didn't find it did, but part of the problem was we also had a ceiling effect. We had 70% of our sample. It was metastatic in that population. With opioid use disorders, we saw lots of ADHD. So we're looking over time, does it predict overdoses and fatal overdoses? We have both. I think we have to look to bigger data sets, quite honestly, because of the rarity. Although it turns out overdoses aren't so infrequent in clinical samples. You're talking 20 to 30%. And opioid users, 20 to 30% who report it. Remember, there's a lot that are not even being reported.
My name is Orrin Mason. I'm a family doc, a psychiatrist wannabe. But I'm proud for just a minute to show off my family practice chops. Russ, the life expectancy reduction if somebody's diagnosed with heart disease is 3 years. And we spend $500 billion a year mitigating that risk. I'm just curious what we should be spending mitigating the risk in ADHD.
Well, it doesn't approach that.
Yeah. Just a
That's
comment.
an excellent point. I didn't realize that. Wow. What a good comparison point to make about the overtreatment of heart disease versus the massive undertreatment of
Exactly. We're still struggling to prove that prostate cancer shortens life expectancy or that treatment lengthens it, both. Mm-hmm. So, anyway, but I actually have a big data question, and that's, this seems like a good technique for looking at one of those vexing problems, which is the rate of psychosis and psychotic-like episodes with stimulant treatment. Is there any wisdom you can shed on that one?
Yeah, so our data show, and this is in PrEP, that ADHD medication is not associated with increased risk of psychosis during periods when they're unmedicated versus off. It's not associated with reduced odds. We do have a paper that if you have a diagnosis of bipolar disorder, okay, ADHD medication will not increase manic episodes as long as you are on a mood stabilizer. If you are not treated with a mood stabilizer, then ADHD medication can be associated with increased risk. Is it due to the medication or due to bad practice? I mean, if you have bipolar disorder, you should probably be on a mood stabilizer. So when we're looking at possible iatrogenic effects, we're not finding it for psychosis.
And that includes, I'm sorry, does that include new incident psychosis?
Yes.
Okay.
Hello, my name's Aaron Winkler. I'm a PGY2 at the University of Maryland in Shepherd Pratt. Thank you very much. I have a comment and a question. My comment is, Dr. Barkley, I'm not sure I've ever had a visceral emotional reaction to a bar graph before, but I did.
I did. Yeah, I did too.
Yeah. And as you, when you've, I hope that the entire country has the opportunity to see that bar graph. I hope the entire country has the opportunity to see that bar graph because it is powerful.
Thank you.
And then my question for Dr. Barkley, Dr. Wilens, and Dr. D'Onofrio is: would it be possible to, as these findings are sort of firmed up, to create like a one-pager or a two-pager that we could provide to our patients that combines all this information in a way that's easily understandable and palatable to parents that we would see and say, you know, just here's this from the national organization?
I think that's a great idea. Certainly it should be directed at the APSARD board. As you know, the CHAD organization and some other philanthropic organizations do publish fact sheets, as does the American Academy of Child Psychiatry, right, Joe? Don't you guys? And other professional guilds have similar types of fact sheets, though not directed at these specific association relative questions. So I think that's a great idea. So Mark is at the back of the room, and Joe is coming in as the next president, and you've got many of the board members here. They could easily commission short fact sheets to go on the website, just like we see at CHAD, and certainly probably being a lot more evidence-based than some of the things that wind up at the philanthropic organizations. Don't you think? Yeah.
Catherine Nicolaitis, developmental pediatrician at Children's Specialized. I have a question for Dr. Wilens. You talked about how alcohol is one of the highest uses of self-medication in the ADHD population, yes?
Yeah, I'm not sure I said, but yeah, because of availability, alcohol is up there, yeah.
And in the younger population, the younger we treat, the longer we treat, the better our outcome is. I'm worried both as a developmental pediatrician, and we follow these kids and invested in those children we treated at a young age as they get into young adulthood and are refusing treatment or are not treated. But we're treated young. Is that protective at all? Did I blink out? Did you comment on that? And as we transition and kick our kids out at 21 years of age, as we talked about supporting them, you know, parental involvement, and those kids are still pretty impulsive or have some of those externalizing symptoms, you know, how do we protect those kids?
So I'm going to hand this off to Brian because Brian can really follow up with that. So I absolutely agree with you. The concern I had, and of course every slide I took out now I wish I hadn't taken out, we would have still been here talking through my talk, but we had an adherence slide, and Joe's doing work in this now, and it's catastrophic. Adherence is terrible. So you do everything right and they come off their treatment. That plus what we know from naturalistic studies, which are most people are not on their treatments, really creates a massive confound of under treatment during culpable vulnerable stage, the age of risk for substance use. And that's one of the, I was teeing off to some of the early studies, and that's part of some of the sort of the lack of effects or in naturalistic studies, yet with these large registry studies, survey studies where we have data on that, we're not seeing that. We're seeing these protective effects. And I was wondering, one of the strengths of these within subject analysis and these large merged claim systems where you can look at what was filled from the pharmacy versus what was the outcome. I mean, ultimately, that's where we're going to have to look to try to really disentangle that. You know, I'm not sure what your thoughts are, Brian, but that's why I'm more and more intrigued with the larger registry studies, especially these large linked merged ones where they have access to multiple claims simultaneously.
Yeah, I would say that we don't have the answer yet for the consequences of long-term use. We can't study it in the US claims data because a lot of people leave our data set after 2 to 3 years. In the Swedish registers that we've looked at, they started collecting information on all the prescriptions in 2005, 2006. So only now are we able to start looking at, well, what happens across 10 years? So people are asking, okay, should I put my 5 or 6-year-old on medication? Well, I think that there's some evidence that parent behavioral training and really in-depth good behavioral interventions are really, really helpful at that age. The accessibility of those services around the country.
I'm gonna challenge that.
Yeah,
I debated the CDC last June. I got into a real row with them over these claims that behavioral intervention should be done first for young children, that it's as effective as medication, that it has no side effects. Those are both flat out wrong, given the database that we have available. Parent training treats ODD, not ADHD, and parent training has side effects. So let me take this to just put a plug in. The next 2 issues of the ADHD report are going to be reviews of the literature on the side effects of all psychosocial treatments used in the management of child and adult ADHD, written by experts on each of those treatments. Psychosocial treatments do harm, and people need to understand that there are these side effects. It isn't just medications that do this. And you know, I'm so tired of this double standard between psychologists and psychiatrists about drugs are bad and psychosocial treatments are good and we do no harm, and that is nonsense. 25% of the kids who go through social skills training get worse because of what that clinician did in that group, and nobody talks about this stuff. So back to that point, behavioral interventions should be used with medication, but they are for defiant behavior, not so much for ADHD. They do have side effects, and they are 1/2 as effective as medication used with preschoolers. So while I think that Brian's point is well taken, you certainly want to be trying psychosocial treatments with or before your medication. Let's not get so far out that we're claiming that there's equivalent effects with no side effects, because that's a non-starter. If you know the literature, you know better than that. And the CDC doesn't know the literature.
So to summarize, the verdict is out. Even if they were treated from young age to 21 and they've stopped treatment, how they're going to self-medicate if they are.
In a lecture
in young adulthood, right?
Maybe Tim can answer this as well, but I got asked to come over to Sweden to speak to government authorities about this issue and the impact of ADHD without managing it and economic stuff. But the point was this: we have, both there and here, a treatment model that needs to be revised. And the model we have is the kid gets dragged into the clinic by somebody else. He didn't call you. She didn't ask for help. She's not committed. If you look at Prochaska's readiness for change, no child is ready to engage a treatment process. And then we're shocked that over time, the supposed patient, this child, begins to not adhere and drift away. Well, they never called you. They were never motivated to get this treatment. They're not committed to change. So what we started arguing is that just before children reach that adolescent, pre-adolescent period, the clinician needs to start to engage them as you would an adult. You need to make them a stakeholder in the treatment. You need to make them own that disorder. Because this idea that I'm only treating the parents and they're going to carry out the treatment at home and everything's going to be wonderful and the kids are going to adhere when they get into adulthood, well, 95% of them leave treatment by the time they're 21 years of age. And that says we're doing something wrong. Yep. You know, don't blame the kid, blame the model. Right?
Yeah. Thank you. This was wonderful.
Yeah, thank you.
Totally agree. Thank you so much. I really appreciated all of your talks. My name is Noelle Lynn. I'm a master's in social work student, and I'll be specializing in ADHD. My question is for Dr. Barkley. You mentioned conscientiousness as the key factor to life expectancy, and I really appreciated everything you brought out there. Do you know of, or are there any therapeutic interventions that can actually increase someone's conscientiousness, and could we use those with people who have ADHD? I very much agree with you on what you just said about therapeutic interventions not necessarily matching the level of medication, but I'm curious if we could increase people's life expectancy by doing something to increase their conscientiousness.
Well, it's a great question. I think, I don't know of any people who have intervened on that personality trait, because it's one of the big five. But if you think of conscientiousness as simply a proxy for what we call self-regulation, which is concern about your future and taking steps to improve your future welfare, then we take a look at, okay, we do have cognitive behavioral therapy programs that have been developed over the past decade to try to improve executive functioning and these deficits within ADHD individuals. And that could be looked at as sort of a proxy answer to your question. Do those treatments work? And the answer is yes. In randomized trials using Murray Salanto's program, Laura Naus's, Steve Safran, Russ Ramsey is here with his program. Adding cognitive behavioral therapy into medication does boost the effect of the medication and does seem to result in some improvement in self-regulatory behavior. And we can then walk from there over, well, that ought to then be improving your conscientiousness. But I don't know. I mean, there are several steps in that inferential process. I don't know of any direct answers to that question. But
I hate to stop because we're going over and the audience is all still here, so maybe we should just continue, but I've been told to stop. If the people who are standing have questions, maybe come to the front, and I apologize for going over, but it just shows that this is an interesting and lively topic. So thank you again.
Well done.
Thank you.
Yeah.
Oh, good. Thank you. They did the hard work, the heavy lifting. Hi.
Yeah.
This is the big thing. Yeah.
Yeah. That's right.
Yeah. Hi. Nice
and yet we blame the kids for not
reviewed every single one of our papers.